Hello and good afternoon, everyone. So, thank you, Ivy, for the really kind introduction and also having me here today. In obesity management or obesity care, we are so used to discussing about weight, body mass index, and percentage of weight loss. And these are really useful parameters, but they do not tell the whole story. With the recent availability of highly effective obesity medication and therapies that we have, we need to ask a more important clinical question. What kind of weight is being lost? And that is the focus of today's session. When we speak about obesity, these chart automatically flash in our mind. The body mass index or BMI values that corresponded with the diagnosis of obesity and classification of its severity. And this way of diagnosing obesity is so much ingrained in our medical or allied health professional training since year one or day one. So, is BMI the only parameters that you use to diagnose obesity? So this slide shows us the problem of BMI very clearly. We have these two gentlemen who have the same BMI value, but they have a very different body composition. Over the left side, these gentlemen have a higher muscle mass, while over the right side, this man has a higher body fat percentage. While the BMI remains the same, but clinically, they have different meanings. So this is why relying on BMI alone may lead us to under-recognize someone's metabolic risk in some patients while overestimating some others. The World Health Organization or WHO defines obesity as abnormal or excessive body fat accumulation that impacts someone's health, be it in physical, mental, or social health. Technically, when we look at this definition, obesity is not defined by weight alone. BMI has a really long history. It was developed as a simple index for population sizing classification and not a clinical tool. It wasn't even created by a clinician, it was by an astronomer, mathematician. But over time, it became widely adopted because it's easy to calculate, easy for us to communicate to lay people and also in scientific committees, and is useful for epidemiology. But clinical obesity care has now moved beyond this. We now have better understanding of adiposity and cardiometabolic, physical, and mental health risks. So the question is whether BMI is enough. Well, the answer is absolutely not. In recent discussion and publication, including the Lancet Commission, we have seen that they emphasize moving beyond BMI for diagnosing obesity. It recommended first to identify whether there is a presence of excess body fat, and next to determine whether that excess body fat causes metabolic or physical dysfunction or both together to the person. In classifying excess body fat, the Lancet Commission has made the BMI optional. It's truly something special from that paper because it tries to divert now away from BMI. You can now diagnose someone having excess body fat by direct measurement of body composition or through two readings of body sizes, which can include waist height, waist hip ratio, and or waist circumference. Of course, if you still want to use BMI, you just add on another body size measurement like the three that I have mentioned. So this is something new and really shaken the obesity care community at that time. Other than obesity definition beyond weight, we now also try to change our views on the treatment outcomes. Just to recap some fundamental in obesity management, there are three pillars of treatment. Lifestyle intervention, obesity management medication or OMMs, and metabolic bariatric surgery MBS. Each of them produce different degrees of weight loss. 5 to 10% of mean weight loss through lifestyle intervention, 5 to 25% through OMM prescription, and about 20 to 40% through MBS procedure. As you can see here, all the outcomes are still in weight loss percentage. Traditionally, when we read all these obesity trials, the treatment trials, they report primary outcomes as amount of weight loss. But again, if we only focus on total weight loss or percentage of weight loss, we miss important details. For instance, a 10 kg weight loss is not automatically means good if substantial amount of that weight loss is from muscle. So the more important question is, what is the quality of that weight loss? Therefore, in managing obesity, we should aim for fat loss because we know that excess body fat, particularly the one deposited in the central region or called visceral adiposity, is well known to contribute to various metabolic complications. And this complication includes fatty liver, or now the terminology called MASLD, diabetes, pre-diabetes, or increases someone's to get cardiovascular diseases. And the underlying mechanism are related to chronic low-grade inflammation and also insulin resistance. Another category of complication is mechanical in nature, or sometimes we hear the terminology fat mass disease. And this includes osteoarthritis of the knees, back, having gastroesophageal reflux disease, and also sleep apnea. So this is also reflected in the latest European obesity management guidance, which emphasizing selecting obesity management medication according to the target complication we want to address. Because some of these medication have higher evidence for certain obesity related complication as compared to the other one. So whether it's about having to help patient to lose weight plus improving certain metabolic or mechanical health quality. Another aspect of weight loss quality is about muscle mass preservation. Muscle is important because of its role in maintaining bodily posture, mechanical function, providing strength and balancing. But sometimes we might forget that muscle is also a metabolically active organ, and it has a role in glucose metabolism and also maintain the baseline energy expenditure. And these are vital factors that determine someone's ability to lose weight and then maintain it for long-term duration. So the clear message here is that with the addition of the initial message, when we treat obesity, we want patient to lose fat. At the same time, we want muscle preservation or increment. But irrespective of the weight loss intervention that we prescribe the patient or the program that we do, lifestyle, medication, or surgery, some loss of fat-free mass is expected. From the compilation of studies we have, it has shown that up to 30% from the total weight loss comes from fat-free mass. And it becomes clinically important when the proportion of fat-free mass loss is much higher or when the patient already has a low muscle reserve. For instance, patients who are elderly. Excessive muscle loss at this time may reduce function, lower someone's energy expenditure, which then increase risk to weight recurrence and also frailty. And the quarter fat-free mass rule by Stephen Henschfield is a useful reminder and also clinical guidance. He said that under standardized condition, weight loss is supposedly to have more of fat mass loss. If can, it should be more than 75%, and the fat-free mass loss should be less than 25%. So that's the quarter amount of the total weight loss. Maximum should come from fat-free mass. If the lesser, the better. Therefore, with that guidance we have, we need a tool to monitor body composition, right? When we treat obesity patient with whatever strategy we use. So here comes the body composition data becomes useful and actionable for us to move forward with the patient. And let us bring this into a clinical case. This is Jane. She is 33 years old and just 6 weeks post sleeve gastrectomy, which is a type of bariatric surgery. And she's taking around 80 grams of protein daily and following a portion controlled plate method, food intake as tolerated. And she's very religiously doing the resistance training about 30 to 60 minutes daily, sleeping 7 hours per day, and taking post-bariatric multivitamin as instructed. And then she was worried and disappointed and tell me that I only lost 5 kilograms. Stephen, please help me. So from the scale alone, she feel very down and asked for my opinion. So I asked Jane to proceed with the first reading of a body composition analysis. Unfortunately, I did not have her data before the surgery to compare. So we have this first reading, and it does not tell us much. It's just like one blood pressure measurement, it gives us information, but the trend is the one that gives us meaning. So after reviewing the first data together with Jane, I reassure her that she's doing great in the lifestyle routine that she's doing and ask her to repeat another readings in 6 weeks' time. During that period of time, Jane lost additional 5 kilograms of weight. And the beauty this time is that I have the impressive data from the body composition analysis. She actually lost nearly 7 kilograms of fat mass while gaining 1.5 kilogram of skeletal muscle. And there was also about 1 liter of visceral adipose tissue reduction. Overall, I told her you had a high quality amount of weight loss, and that is really important for her long-term health maintenance rather than number on the scales alone. So this data reassures Jane that she's progressing well after the bariatric surgery, and the outcome from her lifestyle changes and commitment came into fruition in a numerical data that we can see from the body composition. With all that I have presented and discussed until the last slide, we must understand that weight alone does not equal to health. The number on the scale cannot tell three important things. First, the body composition. What is the body made of? Second, distribution. Where is the fat store? Is it subcutaneous or visceral one? Thirdly, function. Is muscle strength and physical performance being preserved? All these cannot be told by the number on the scales alone. I need to repeat this multiple times. That's why we are having this discussion. And I see that in the last two polls, majority of you telling about body composition as one of the key answer, whether to diagnose or to monitor the outcome from treating obesity. So we need to understand the terminology that we are dealing with. So fat mass means body fat, while fat-free mass means everything else except fat. And that includes water, protein, minerals, bones, organs, and muscle. Lean soft tissue is fat-free mass minus the bone mineral content. So skeletal muscle mass is as it is. So these names matter because the terminology such as lean body mass, lean mass, and lean soft tissue are really often interchangeably used in publication and confusing, but they are not the same. So the preferred terminologies are the one that listed here. Body composition models divide the body into compartments. And the simplest one is the two compartment or 2C model that provide the readings of fat mass and fat-free mass. Moving on, next is the 3C or three compartment model. And the 3C models can have two meanings. The first one is the DEXA scan reported body composition data, which separates the fat mass, lean soft tissue, and bone mineral content, as you can see in this slide. However, for those in this body composition field for a long time, actually the 3C models for them refers to a multi-device assessment that separates between the body mass into fat mass, total body water, and fat-free dry mass. So the 3C model, it depends on who you are talking to. Usually clinician will understand as presented in this chart, but those into the science or research of body composition, they might mean other things. And finally, the four compartment model, 4C model, separates fat mass, total body water, protein, and bone mineral. The key principle is simple. The more compartments we have, means fewer assumptions. For instance, the 2C models assume fairly constant bone mineral density and water intake. But in real patient, for example, we are seeing patients with obesity, older adults, those after bariatric surgery, and those on the way losing weight, which using whatever methods they are using, this assumption may not always be true. Ladies and gentlemen, this is the key point here. The 4C model is considered a reference model because it combines multiple measurements. And I have friends who are into body composition. He always mentioned about this 4C. And before I dwell into this field, I just wonder what 4C is about. So we can see that it uses the body volume, body mass, bone mineral content, and total body water to separate these parameters. And that means we need multiple device and methods of body composition assessment. This combined assessment then reduce assumptions and is very useful for research. Moving forward, we are now talking from composition to body fat distribution. This slide shows us that even individuals with similar BMI and body fat percentage, the visceral fat content may differ. I know a lot of news among us clinicians is that don't focus on weight, don't focus on BMI, focus on body fat percentage. But in body fat percentage, the visceral fat content is the one that's important. So with a similar body fat percentage, the visceral fat content may differ from one individual to another individual. And this is reported as a visceral adipose tissue or VAT. And why we are so obsessed with this VAT? Because these are the metabolically active fat that strongly linked to the pathophysiology of many metabolic associated disorder like diabetes, hypertension, etc. So because of the insulin resistance, chronic inflammation, and then increases the cardiometabolic risk. So again, body weight often misses the mark about health. Body fat percentage is a useful guide, but VAT are the ones that more precise that associated with disease state. So that naturally brings us to the next questions. How do we assess body composition? And there are many methods to do this. Some are accurate but less practical, while, as we know, there are other more accessible methods but rely on prediction models. MRI and CT scan provide detailed tissue imaging, while DEXA scan is a 3C model, which I have discussed previously. MRI is also very expensive and needs a long time to perform body composition assessment. And patient needs to go through that, that hollow machine and wait for quite some time, up to 1 hour. CT and DEXA scan have some radiation exposure due to the X-ray use. So there are two methods to assess body density. So we are now moving towards body density. The first method is shown in the third picture over the right side. It is called underwater weighing or hydrodensitometry, which use the Archimedes principle of water displacement. You can see here in the picture, it needs special equipment, preparation, and also space. The second method of body density measurement is through air displacement, plethysmography, or the brand name called BODPOD. I have this in my institution too. And as compared to underwater weighing, the equipment and skill required to conduct this test is easier. Though the patient preparation, I think, is still equally troublesome. As you can see, there's one gentleman wearing swimming suit going inside the egg-shaped parameter device board pod. So there are other methods of body composition assessment, for instance, like deuterium dilution to assess total body water, skin fold calipers to measure subcutaneous fat, which are inexpensive but really operator dependent. So I used to do this during medical student time. The lecturer from nutrition department will teach us this method. And the next method is a bioelectrical impedance analysis, BIA, which is a tool commonly used in clinical practice and because it's widely available. So when choosing a body composition method, there are few characteristics I want to balance. For instance, like what I've discussed in the poll, the accuracy, reproducibility of this data, the speed to conduct the test, the cost involved to the institution and also to the patient, accessibility, safety, and practicality. And I think the ones the body composition assessment tool that truly fulfill each and every of these criteria is BIA, and it offers a balance. Some may be stronger, some may be weaker, but at least it constitute all these things. It is fast, non-invasive, there's no radiation involved, relatively affordable to the patient, and practical for repeated measurements in the clinic. This slide is important to help us understand two important terminologies: reference versus estimation method. So the reference method means here MRI, CT scan, DEXA scan, and 4C model, which are used to measure or validate body composition accurately, while estimation method such as BIA uses equation and assumption to estimate body composition, which is then validated against this reference method. So reference is the thing, like we say, the standard that the estimation method used to refer on. So now we'll try to understand how actually BIA works and what are the assumptions. What happens when someone is on the BIA machine is that this machine sends a very small harmless electrical current through the whole body. And there are a couple of fundamentals we must know here. Muscle and water conduct current easily. Therefore, it has lower electrical resistance. Second, fat contains less water, so it has higher electrical resistance. So then the device measure impedance and uses prediction equation to estimate body composition parameters such as fat mass, muscle, total body water, and visceral adiposity. And for BIA, there are various kind of devices: hand to foot device, hand to hand, foot to foot devices. So hand to foot devices, as shown in this picture, are generally better than those hand-to-hand and foot-to-foot devices because the electrical current pass through nearly the whole body. And another one practical point from my clinical experience using the seca mBCA 555 is the importance of entering the waist circumference data into the whole picture. And this helps improve the estimation of VAT, the visceral adipose tissue, the fat that is really important for us to look at. Not all BIA devices are the same. For obesity care, the physical design of the device is important for me. I need it to have a sufficient weight capacity up to 300 kilogram because I see patients up to 250, sometimes 260 kilogram. I want it to have a sturdy handrail and a wide and low platform that contributes to good patient safety. This is especially important if patient having BMI 50, 60 and up to 80, or they have osteoarthritis, they are older adults or have reduced balance. Positioning also matters. The legs should be separated to prevent thigh-to-thigh contact. I want you to imagine patient with BMI of 50, sometimes their thighs are really thick, both sides, and they may have touch in between of both thighs. That will causes a alternative current passage and makes the lower body composition analysis inaccurate. Therefore, for the seca mBCA, it has a marker there. When you measure the height using the ultrasonic height measurement, the feet are together. But when you measure the body composition, it will ask you to separate the feet. So this is one of the key features that I think is very useful for obesity care. More so, the hand electrodes also has a similarity. You can either put in front, but for patient with severe obesity, when you do like this, sometimes there's arm to torso connection whereby the alternative currents will happen. Therefore, we can put to the side and the arms are abducted. So that's the reason why we have two places to put. You can choose depending on the patient body size. Beyond the hardware of the machine, we should also consider how this BIA fit into our clinical workflow. Is the data entry easy? Is there a online software? Can patient review the progress easily? My experience is that yes to all, and I can ask the patient to measure their body composition first. They go up to the machine, measure, and then automatically link to their clinical profile. Or the other way around, my nurse is ready, open up their profile and click start, and then measure the body composition. So all these data are then captured in the online software, which is easy for me and patient to review, be it on the desktop or the patient has a mobile apps to review together. So another important aspect of BIA that I look at is whether the patient report can be customized. Let me tell you, the seca mBCA parameters, there are huge load of the data there, and not all I understand, and not all are relevant in obesity care. So I need to customize what are the relevant information that the patient should know to avoid information overload. So thankfully, the machine does that. And I like to use the nutritional and functional assessment option over the right upper corner there, which I call it the obesity care parameters, because it includes the BMI, VAT, fat mass percentage, and muscle mass. I just don't want to overwhelm the patient with all the parameters available in the system. The other highlight here is the trend view. Like I said, I'm like a broken record repeating this. A single reading can be affected by hydration, food intake, exercise, and others. That's why repeated measurements is the one that helps us clinically make decision and show us the direction of the patient treatment plan. So I tell patient, don't overinterpret one single reading. At least now we have the baseline. We are looking at the trend. The trend is the one that helped me decide the treatment plan. Another function that we have in the machine is treatment tracker. It plots the body composition chart over the y-axis fat-free mass, fat mass, or even weight against what treatment is being used during that specified period. For instance, this patient was started on tirzepatide over 2.5 months ago. So I can see here that there is 5 kilogram of weight loss, and the fat-free mass loss is only up to 15%. So this is less than the quarter FFM rule. So if there's any changes in the treatment plan, we can add or delete from down there. So we can see how the patient body composition fluctuates depending on the treatment plans that we give. So I think that the treatment tracker really upgrades user experience in using the software. Here comes the science part. Validation of our tools is very important because we are doing the business of science, helping people. We want to know the things that we do is correct based on real science, and validation is part of the science. The seca BIA system has validation data comparing muscle mass with full body MRI, fat mass with the 4C model, and total body water with deuterium dilution. And all these validation studies are up to 98% accuracy. At the same time, the seca BIA also validated with reference population of diverse ethnicity and age group, from children more than 5 years old to elderly adult more than 65 years old. For me in obesity medicine, I'm very delighted to see that there are even data for patients up to BMI 50 plus. In the previous case sharing, I shared about good quality weight loss and how it looks like from the body composition report. And these slides illustrate the opposite side, the poor quality weight loss in another patient that I treat. So this patient, from number on the scales, showed that 3 kilogram weight loss after 1 month treatment on phentermine. And it sounds like a win. And we might even praise the patient for the progress. You lost 3 kilogram, that well done. But the body composition is telling another story. His BIA showed increased fat mass and visceral adipose tissue, while his muscle mass reduced by 1 kilogram. So this may happen because lower protein intake, there's no exercise, no resistance training, and patient not eating enough. So it alerts us that this is poor quality weight loss and we need intervention. So what should we clinician do when we detect such scenario? Or having said that, patient probably start off with a very low muscle mass. I will definitely intensify the patient lifestyle changes plan, or even start a patient on structured lifestyle intervention or program if they have not already done that. And this may include dietitian or exercise physiologist referrals. And then for me, I will have a closer review intervals. And depending on the cases, if they are on medication, I may think of reducing the dose or slow down the titration upward. I want the patient to gain health and not about losing weight per se in treating obesity. Here comes another part, is that muscle mass alone is not the full story. A patient may have low muscle mass, but what really matters clinically is whether this is affecting that person mobility, balance, daily function. And here comes the concept of sarcopenia. Generally, right, among us healthcare professionals, we always thought sarcopenia is just about the low muscle mass. But from definition, we know that it includes reduced strength and impaired physical function for some definition. Therefore, apart from body composition assessment, focusing on the muscle mass, there are some simple functional assessments such as hand grip test and chair stand test are important for us to assess the patient holistically. So quality weight loss is not just about preserving muscle quantity now, it is also about preserving or improving muscle function. This is my last slide. Let me end with these main messages. We must now look beyond weight in diagnosing and also monitoring obesity treatment. So quality of weight loss is what matters. We want fat loss, while especially the visceral fat, while maintaining or increasing muscle mass of the patient. And to monitor that, we need body composition assessment and repeated readings. The seca BIA is one of the good options because it combines clinical practicality with validation against reference methods, and it also user friendly, be it for patient or healthcare professional like us. Thank you very much. I hope this session helped us move from asking only how much weight did the patient lose to asking the more clinically relevant question, that is, what was lost, what was preserved, and how did the person health improve under our treatment and care. Thank you, ladies and gentlemen. I look forward to the question.